Good morning, everyone. How are you? Just going to talk about a couple of papers that frequently get quoted in the intra-lumbar flexion debate in regards to low back pain. And what's interesting about them is that they kind of go against all of our observations that we make in clinical practice, and that's observations over many, many years in many thousands of patients with acute back pain, relapsing and remitting back pain, and chronic low back pain. Remembering that those different cohorts of patients have very different responses to treatment, noting that acute back pain has a tendency in the vast majority of people to simply settle down spontaneously with time, regardless of what intervention is applied. The real test of whether your intervention has a strong cause and effect relationship is whether you can resolve someone who has many, many years of low back pain with your therapy. So we kind of know that most patients who present to us with exacerbations of their chronic back pain or an acute flare-up of back pain will generally describe some form of bending task that triggered their pain symptoms. Okay, that is non-conjecturally the what people say. I bent forward to pick up something, and it doesn't have to be physically demanding. It could have been just bending forward to pick up the mobile phone off the coffee table, and that was the trigger for a severe flare-up, or at least that is existing within their long history of low back pain flare-ups. And then they become a chronic pain patient over time, where the pain simply doesn't ever resolve no matter what you throw at them. So when articles like this, to flex or not to flex, is there a relationship between lumbar spine flexion during lifting and low back pain? And then also the other article, which is a review of workers with low back pain and without low back pain, and an assessment of their bending and lifting technique. So these articles fly in the face of our clinical observation. And so what do you make of that? Do you simply go, oh, that must be real, I'll just completely abandon all of my experience over the last 20 or 30 years and thousands of patients and just start singing a new tune? Well, I don't think so. I think you've got to be critically thinking, and you've got to read between the lines and look at the data that's being presented and think about where the misinterpretations could lie. So let's do that. These papers are written by the same authors, and that's surprising in itself. It's separated by 3 years. I think there's just one author that's not associated with one of the papers. And here are some inherent problems with the conclusions drawn by the authors. Despite low-level evidence being described, an assertion is put forward leaning toward the bias of the authors that intra-lumbar flexion is not injurious. The authors observe that a worker with low back pain has less intra-lumbar flexion, or a worker with no low back pain demonstrated more intra-lumbar flexion. So that's really the sticking point in the conclusion. So they wrongly conclude that a causative link, that a more neutral spine is more hazardous, or conversely, a flexed lumbar spine is protective. No consideration is given to the fact that in the presence of pain, compensatory and protective hypotonia and muscle bracing is highly likely to result. This very simply accounts for the misinterpreted observations and what I believe is a falsely drawn conclusion. Think about how your protective muscle spasms and restricts your movement when you've had a painful strain injury anywhere in the body, really. So, in addition, no consideration is made to the likelihood that the no low back pain group of workers were not accumulatively developing injury in their spinal structural integrity, i.e. at a subclinical state, and they were just going through life in a pre-injury state due to that repetitive intralumbar flexion and bending. No consideration is given to the discussion of stability being maintained with lifting and bending tasks, regardless of whether intralumbar flexion is occurring or not. This element must take into account the relative demand of the load on the individual and their passive, active and neural control factors, which, non-conjecturally, all influence stability. Of course, if the load demand is very low, stability can still be maintained regardless of how you coordinate your spinal position. The problem is that most patients with chronic back pain have very poor functional capacity and therefore easily have an unfavourable mismatch between their daily movement requirements and tasks and their ability. Without even dedicating one sentence to these critically important elements, it's abundantly clear that the authors are unfamiliar with movement theory and unlikely to be well practiced in lifting technique. So the take-home message is trust your instinct, think critically when research conflicts with your long-standing experience. You'll often be able to see flaws in the conclusions and in the design of the trial and the acquisition of data. Finally, get some calluses on your hands in the gym, lifting heavy barbells, sandbags, kettlebells and dumbbells, and the research observations will begin to make more sense. The final conclusion drawn will then support the fact that we promote proficient biomechanical movement technique matters. Our own research over the last 8 years has already demonstrated the healing capacity of defined functional movement proficiency in the most damaged chronic back pain patients, which supports a strong cause and effect relationship. All the best.